Good morning, good afternoon, good evening, good late night, early morning, again, all depending on where you're from. We've already had some people, Margaret dialing in from Canada, a couple of folks, Margaret's from Winnipeg. Margaret brings up a good point. She said, "Good morning from Winnipeg. Hit the like button while we wait." And it's like, Margaret, I agree. We get so many people on and they just don't do the like button. Gosh, if you're going to spend this much time on a show, at least help us out and hit that. I appreciate it. Anyway, enough of a rant for that. You didn't dial in to hear that. Today you dialed in. Hopefully you dialed in for some good Q&A. And today we're going to be serving up some of the new information about the new anti-diabetic drugs. Now, we're going to talk a lot about drugs for the first 10, 15 minutes. And, it's so interesting. So many people dial in, they hear one thing about drugs, and then they say, well, this is not all about drugs. This is about lifestyle, doc. You don't understand. Ken Berry, he's got a good show. I like a lot of his stuff, but it's like he saw one video, and in my estimation, probably less than that one video, and made a quick comment about, well, you seem to be dependent on drugs. Anybody that would say that about this channel has, again, probably seen less than one video. There's no question lifestyle trumps supplements. It trumps surgery. It trumps bypass. It trumps, for sure, it trumps medications. But at the end of the day, these are all tools. Now, and they're tools that we need to be aware of. For example, a large portion of what we talk about is how stress tests don't really predict heart attacks very well. And guess what? There was a comedian. That's what this whole book was about. If you think that you've got risk for heart attack and stroke, don't do what the vast majority of the world does and say, hey, doc, could we get a stress test? Stress tests don't predict heart attack and stroke. In fact, there was a well-known comedian, not well enough known that I could remember his name, but we'll be covering it. But it became an issue. We had a couple of viewers send us the information on it. This comedian had a stress test, passed it, no problems at all, had a heart attack within just a few days. And it's like there was a lot of media coverage on it, and the viewers were saying, hey, doc, you should have been there. They had it on Fox News, and they should have put you on there. Well, you know what? It would have been great. I'd have been happy to be able to get this message out to that viewership. But bottom line is there's a lot of folks that are getting this information, and sure enough, it's having an impact. So having put that context around the issue that lifestyle is multiple times more important, as in 3 to 5 to 10 times more important than any drug. Like we said, there's a time for prescription drugs, and there's a couple of new classes of prescription drugs. We've covered them multiple times as these classes have improved, and the evidence around those drug classes has become clearer and clearer. We're going to get a little bit deeper today. We've actually talked about them a couple of times, and we're going to cover the evidence out of 5 different articles, which again just show that these drugs are, number one, much safer than previous options, with the majority of the previous options for serious diabetes being insulin. And both of these drug classes are so much safer than insulin. Both of them show very little risk. Many people would say no risk for hypoglycemia. I'll never say never and no risk, but very, very little risk compared to insulin. They have also very little risk in other areas. But here's the big thing with these two drug classes. Both of them are showing significant decrease in risk for the real issue, The real risk with diabetes and prediabetes is not more diabetes. The real risk is heart attack and stroke, blindness, kidney disease, cardiovascular disease. And that's what, people get confused about the term cardiovascular disease. They get focused on the cardio part, the heart part. It's not cardiovascular disease so much as it is vascular disease. That is the problem with diabetes. And both of these drug classes are coming on board, and the evidence is piling up that for diabetics, these have little to no risk compared to the other options, the types of insulin that we've had in the past. And most of all, they're decreasing the risk for heart attack and stroke, for vessel disease, vascular disease. So as you see, if you've never been on our channel, we talk about the things that kill and disable us more than anything else: vascular disease. Recent previous topics include intermittent fasting, impact of intermittent fasting on aging and cardiovascular disease. We like to have patients come on board when they'll tell their story, because it's so much more real when you hear a patient than it is when you just hear a doc talk about technical stuff. Dana Stewart was our patient a couple of weeks ago. She showed a major demonstration of discipline. She emphasized the importance of sleep in her space. I can tell you, as we age, sleep becomes more and more important and more difficult, especially as we lose weight, which many of us need to do. Some of us don't, but she needed to. She was clear about it. Not only did she lose weight, she was able to increase her sleep dramatically while she did it. Again, very unusual response to some very common challenges. Another recent topic: the low-fat diet versus other diets for weight loss. And just a spoiler, that was the problem. When you looked at that study, low-fat diet did help for weight loss, and it did it about as well as some of the others. But here's the issue. Is it weight loss that we're looking for, or cardiovascular risk? Weight loss is a huge deal. It is one of the biggest deals for most of us for heart attack and stroke risk, but not for all of us. And there are some metabolic issues that we need to be looking at. You tend to not get those so much with low-fat diet. A couple of other things. So again, if you've not been in the channel, we've got a lot of content. We're making more and more of it free. Michelle and the team and I worked this morning about how to get these courses. Unfortunately, the science and the evidence is really clear that the vast majority of doctors really don't understand how to diagnose prediabetes, let alone how to manage it. So it's, back in the old marketing, it reminds you of that old marketing phrase, buyer beware. Unfortunately, it's true. If you're a buyer, a consumer, a patient, you need to be aware that your doc doesn't know enough about the things that really kill you, really disable you: heart attack, stroke, dementia, and how to prevent them. And within just a few hours, you can learn more than at least 70% of primary care docs, more like 80 to 90%, about how to stay healthy. So we're working on that and making that information much more available. Now, just a couple of comments. As we mentioned in the past, we're expanding our access to folks. We know that there are some folks that are more into Rumble. Rumble's all about getting away from potential review, taking things off, having Big Brother look at your content. And Rumble doesn't do that. So the folks at Rumble asked us if we would be interested in setting up a channel, and that's exactly what we've done. The channel is up and rolling on Rumble now. And we will be we're getting content up and rolling for Locals as well. In fact, Locals provides much better access for more of a community type of approach. And we will talk more about the type of content that we're getting out there for both of those outlets. We've got, again, continued growth with the Jubilee program here in Alabama. And in fact, one of the things that we're doing with what we've learned at the Jubilee program, we're strongly considering the option of transferring the channel practice over into a Medicare/insurance program. And I know this is an early statement. We're not there yet. It'll take weeks minimal, probably months, assuming we do make that transition. But if we do, just think of the improved access that folks can have to this life-saving care. I mentioned the book earlier. I'm not going to take your time covering that. I'm going to go straight into the pre-show content. We often have a shorts version, and this is our short today. It's on Zypitamag. We've mentioned it a few times. There's only, statins are great. And again, people say, oh, I hate statins. I think, in fact, there's probably not any cardiovascular drug that is more hated than statins. And in fact, I don't really use statins nearly as much as your typical doc because I don't agree with the typical indication for statins either. The typical indication is if you've got an LDL over 70. As you may have seen from my channel, I'm far less concerned about the absolute LDL level. And you can, I'm not going to go down that bunny hole. But I do prescribe statins. I recommend statins, and I take them myself if you've got plaque. Now, why is that? Because the issue here is not so much plaque squeezing off the flow to your arteries. That's actually why a stress test doesn't work. The issue is not squeezing off flow. The issue is cardiovascular inflammation. In other words, your arteries taking friendly fire. In other words, your own inflammation system dissolving that plaque, and that dissolved, hot, inflamed plaque causing a clot. Why did I go down that bunny hole? Because of this issue. That's what statins are really most appropriate for, in my mind and in my practice, and if you start looking at the science. And it's low-dose statins. You don't need high dose to accomplish that decrease in cardiovascular inflammation. Now, what's the downside? On most statins, in fact, all of them except one, can increase insulin resistance, the most common cause of this problem. So it's like you're balancing the risk of increasing the major cause of this problem against the benefit that it brings of decreased inflammation. Well, there's actually one statin that doesn't do that. It's pitavastatin. What's the problem with pitavastatin? Well, if there's a drug that's got a major benefit, guess what? If Big Pharma can make money on it, that's exactly what they'll do. And Big Pharma is making huge amounts of money on pitavastatin. Now, one of the things that happens as a drug starts to mature in the marketplace is they start making different types of generics. Zypitamag is a type of generic. I won't go into the details. Technically, it's hard to describe and hard to wrap your head around and really not worth the extra time. But there are ways these days already now to start getting much more cost-effective Zypitamag. And we make that, we do that. Michelle works that out for a lot of our patients. Just wanted to make sure that folks were aware. Now, I got disappointed last week. Somebody made the comment that, Doc, you're so, they made the comment that I'll have word finding problems. And I agree. I don't have the greatest speaking skills. I know I don't. I never pretended to. I just sort of muddled through. And one of the speaking skills problems that I have is word finding. I will be thinking about something and I will try to get that word and I'll just start saying, wait a minute, you know what I mean? You know what I mean? So last week, I was thinking of this word and I came up with the wrong word. I came up with hermeneutics. And hermeneutics, for those of you, there were a couple of Bible scholars on and they said, that's old document scholarship like you usually see in biblical stuff. And I was saying, yeah, that's right. That's not the word I wanted. Nobody came up with the word. I was looking for the concept, and you see it in toxicology. I did a lot of toxicology as a medical director for a lot of companies, in work related medicine, occupational medicine. Workers can get exposed to different things like lead or other, quote, poisons. And there was this concept of hormesis. Believe it or not, there was somebody later on that came up with that word. Now, I had already thought about it, but kudos to Daniel Trevor. He remembered that word. He saw the video late and he said, hey, Doc, you were looking for the word hormesis, not hermeneutics. So we got together and we said, you know what, we're going to, evidently, a lot of people don't know what hormesis is. And it's like, if you don't know what hormesis is and you're interested in the science of prevention, you need to know. So here's what hormesis is. It refers to a paradoxical dose effect or time effect relationship for a substance. Mostly where we're talking about, it might be a poison if in larger doses, but in a smaller dose, it's good for you. Now you say, well, that sounds very technical. Well, let me just back up and say, every one of you knows about this. Think about it. What is high intensity interval training? What is any type of exercise? They are hormesis. You're stressing the body. So when you relax the body, when you heal, the body comes back at a higher capacity, stronger and healthier. That is hormesis. So this came out of an article, Trends in Endocrinology Metabolism 2019, Baylor College. And I just wanted to get that into the content to start getting that concept out there. We'll go a little bit deeper later, but just a couple of quick comments about it now. You look at the opposite. They say too much of a good thing can be a bad thing. And that's true. Both of these concepts are very, very true in toxicology. You talk about, well, that's a poison. Air can be a poison. Oxygen can be a poison. And in fact, oxygen damages a lot of humans every day. Really? Yeah. Too high a level of oxygen damages a lot of things. And especially with infants, premature infants, you get a lot of oxygen damage for those folks. You also get oxygen damage, gas damage, nitrogen damage for divers. I'm not going to go down that bunny hole, but it makes the point. Too much of a good thing is a bad thing. Let's flip that over on its head and you realize sometimes a little bit of a bad thing can be a good thing. Like stress. We all say stress is terrible. Physical stress, pushing, can be hard on your body. And that's exactly what we recommend in controlled amounts with high intensity interval training and resistance training. Now, it's known that oxidative stress causes aging, but low levels of reactive oxygen species, for example, can function as signal molecules with some beneficial effects. Insulin can be a good example too. You want insulin to help you manage your blood sugar when it's time, but too much insulin, too much time period, high levels of insulin on a regular basis has been demonstrated to be a major driver of cardiovascular inflammation. So There are other examples too. Even you look at the quote, couple of the antioxidant supplements, vitamin C and E, in high levels, they have some reputation for causing increased risk of cancer and diabetes. So again, the word that I couldn't remember and I was substituting hermeneutics with was hormesis, the word for the week. Now, if you'll give us the water ball, we'll get to the topic of the day, anti-diabetic drugs. So good morning. As you might be able to see, we're broadcasting from the Alabama project office, and I mentioned it earlier in the comments. Technology, there's under the category of it's always something. About 2 minutes before we started, I started hearing one of our carbon monoxide alarm batteries going off. So we may get some chirping during the show. I hope not, but if we do, we do. Having a problem never, rarely stopped us. So today's show is about the additional benefits of the new anti-diabetic drugs. I have been encouraging a lot of people to consider these. And, like most of the folks on the channel, they say, I'm not so sure. I will tell you, and the biggest reason for most folks is that they're expensive. I'm a physician and I'm sharing a lot of medical stuff. Very few physicians were trained in preventive medicine. I trained in preventive medicine at Johns Hopkins. I went on to teach preventive medicine to the doctors there at Hopkins. And so you get a lot of docs talking about prevention. Just very, very few of them actually got trained in it. So I talk about medicine, but I'm also a patient. I turned 65 this month, and I am scheduled for my AWV, my annual wellness visit, later on this afternoon. And I'll be talking with my new doc, who's one of the doctors at the Alabama Project, by the way, Ryan. He's been on the show a couple of times. He talked about atrial fib. If you haven't seen his video on it. I'm going to be talking with him about these two drug classes for myself. And when you look at it, you might say, well, Doc, are you really diabetic? Well, I've had a couple of blood glucose values over 200. I fit that technical diagnosis. Well, Doc, should you really? Because you've only got like one druce, one component of the eye damage. And here's the thing. No, I don't know. I mean, I think it's a great conversation to have with another doc that's knowledgeable about this issue. I'm strongly considering it. A lot of times I've taken drugs that I don't completely need, just because as a doctor, I wanted to make sure that, I'd had that experience. I obviously haven't done that. Maybe it's not obvious. I haven't done that with mental health drugs and things like that, but I am certainly considering it for these. I don't have a strong need, but I may take one of the categories for a month or two just to experience it. Now, why would I do that? I mean, aren't there downsides? Of course, there are downsides with every drug class, drug category. And what are the downsides with the two categories we're talking about? Well, with the two categories we're talking about SGLT2 inhibitors and GLP-1 agonists. The SGLT2 inhibitors, basically, their mechanism is to trick the kidney into letting glucose spill out. So the way the kidney works is it's a filter, and then so it filters stuff out, and then sometimes it'll pull things back in that it didn't want to filter out. You can't have a filter. The way the kidney works, it doesn't just selectively filter. sometimes it filters stuff out that it didn't want to filter, and so it just reuptakes those or reabsorbs that. The blood sugar, when it's too high, will filter through the glomerulus, the filter membrane of the million filters in each kidney. Further down the urinary collection tubules, we will reabsorb that glucose. SGLT2s stop that reabsorption process. So basically, you just pee out or you urinate out extra glucose. The mechanism for GLP-1s is it's a GLP stands for GLP, glucagon-like protein, and glucagon is a satiety hormone. It helps us feel like, okay, I've had enough to eat. It stimulates that, it stimulates that protein. It actually stimulates pancreatic insulin secretion. It mimics that hormone, so it decreases your appetite. And actually, some of these drugs, the GLP-1s, are used for significant weight loss. And we'll talk about that a little bit later in the show content today. So what's the downsides of these drugs? Well, with the GLP-1s, because of their stimulation of pancreatic insulin production, you can actually get overstimulation of the pancreas. There is some risk for what we call MEA, multiple endocrine adenomatosis. Again, a technical term. Bottom line is some types of pancreatic tumors. And so that's what the risk is there. And it sounds very, very scary. You just put that together, though, and balance that against diabetes. There are times when these make sense. And in fact, as you look more and more deeply at these, and as you look at the science that we'll cover, the risks associated with diabetes, insulin resistance, are much, much bigger than the downside risks of these two drug classes. What's the downside risk for SGLT2s? Well, because you're spilling urine, glucose in your urine, then you have some risk associated with infection. You can get a fungus infection of your private parts. So again, I'm going to go on script. I know that I don't do well. I lose people in terms of conversation when I'm not on script. Let me go on script and be a little bit clearer. SGLT2s, sodium glucose cotransporters inhibitors. They decrease renal glucose reabsorption. Here's some brand names or some drug names: dapagliflozin, empagliflozin, canagliflozin. Now, the GLP-1s stand for glucagon-like proteins or peptides, agonists. They stimulate pancreatic insulin secretion. Here's some examples of that: semaglutide, exenatide, dulaglutide, liraglutide. And these are, for the most part, injectable. There are a couple of them that are not injectable, pill form. Ozempic is one of those versions. Ozempic, by the way, is a drug. It's a GLP-1 agonist, which is used for weight loss. SGLT2 inhibitors and GLP-1 receptor agonists. Here's a review article, and it covers both of them. It was in Lancet, one of the leading medical journals of the world, back in 2021. It's published out of London. The title was, it was in Therapeutics magazine, and the title was SGLT2 inhibitors, GLP-1 receptor antagonists, established and emerging indications. It's one of 5 studies that were included. The SGLT2 inhibitors that were especially useful in patients with heart failure and chronic kidney disease. So as you see, there are patients like me. Most of my patients are about at my level. Some have far more significant disease in terms of heart failure. Some have more significant disease in terms of of active diabetes. Once you get into those categories, these drugs become much, much more important. On the GLP-1s, for people with established cardiovascular disease, overweight, and obesity, as I mentioned before, the GLP-1s are very popular for weight loss. Semaglutide was one of the original GLP-1s to come out in terms of overweight and obesity in the #1 journal, New England Journal of Medicine, 2021. Once weekly semaglutide in adults and with overweight or obesity. This was a very interesting article. Excuse me, it was a blockbuster in terms of the obesity community. 1,961 non-diabetic subjects were enrolled in this study. They compared a 68-week treatment of semaglutide, one of the GLP-1 agonists, versus placebo. With both of them, they included lifestyle intervention. The mean change in body weight from baseline was 14.9%. So we're talking about for a 200-pound person, that's 30 pounds in the semaglutide group as compared with 2.4% in placebo. So it's like now you see those numbers and you begin to realize how important these drugs are going to be. You put that together with the knowledge of the obesity epidemic, and it's like, oh, so that's what this is all about. And that's true. It's not the only thing that this is about, but this again is a blockbuster indication. More participants in the semaglutide group achieved weight reduction of 5% or more. And this was Novo Nordisk, for those of you who are interested in the pharma associated with it. Liraglutide, another one of the semaglutide, and then they did one with liraglutide. This one was also in New England Journal, 2021, out of Denmark. Healthy weight loss maintenance with exercise, liraglutide, or both combined. They did 195 non-diabetic subjects for enrollment. There was an 8-week low-calorie diet. Participants were randomly assigned for 1 year to one of 4 strategies: moderate to vigorous intensity exercise program plus placebo, liraglutide plus usual activities, liraglutide plus therapy, or placebo plus usual activities. All active treatment strategies led to greater weight loss than placebos. In other words, liraglutide beat out placebo. The liraglutide combination strategy led to greater weight loss. It's the only one that improved hemoglobin A1C. It was the only one that improved insulin sensitivity. And it was the only one that improved cardiovascular fitness. Or cardiorespiratory fitness. So again, you start to see what the interest and what the importance is. Guess who was involved with that one in terms of pharma? Yep, Novo Nordisk. Impulse study, Nature magazine, 2022, US, Germany, Spain, Italy, Norway, China, and others. This study included 530 hospitalized patients with acute heart failure or decompensated chronic heart failure. Patients were treated with empagliflozin or placebo for up to 90 days. More patients treated with empagliflozin had clinical benefits, reducing death rates, heart failure events, and heart failure symptoms, and showed to be well tolerated. So again, you think of these new drug classes as, oh, you know what, that's just for weight loss, which that's not in my category. Well, no. Weight loss is a very important category, but guess what? Heart failure is also a huge category. In both of these categories, weight loss and heart failure have been extremely difficult to deal with for the medical community. So again, lots of information, lots of promise coming up with these new anti-diabetic drug classes. I expect to get a few haters talking anytime we talk about prescription drugs, but we'll deal with see if we can get better at dealing with the trolls if and when they come on board. And I will be quiet. So for a second, while Gilbert puts up the transition for Q&A. So there we go. Let's see what we've got in terms of, well, we've got a lot of interest here, actually more interest than I expected. Fort Worth West Side. If one has checked their blood glucose after eating and established what foods don't raise blood glucose and stick to those type foods, drinks, is using a CGM still a good idea? And if so, why? You know, that's very interesting. It's a great question, Fort Worth, and thank you for asking it. I get that a lot from folks. They say, well, you know, I had trouble with this device. It's not exact, and I get frustrated. I expected it to be exact. I got a couple of bad, you know, Libre is still notorious for giving you some bad sensors sometimes. Here's the thing. For those of us baby boomers who are in this middle-aged category now and are dying, falling, becoming disabled due to insulin resistance, this is the most important thing for us and for our health. And it's sort of like driving a car for 60 years, never having a speedometer. You know, you get these cars, especially these days, and you go faster and faster and faster. And if you don't look at the speedometer, you look down and it's like, gosh, I was going over 80 miles an hour. That's still dangerous. Guess what? We've never ever looked at our blood sugars. So that's the importance. It's like for the first time ever in our 60-something years, 70-something years, 50-something years, that we've actually been able to look down and measure the most important risk factor for our life. Now, so as I typically do, Fort Worth, you know, you reminded me of an issue. I went down the bunny hole, but I didn't really answer your question. A lot of people say, well, okay, I've dialed it all in. Do I need to check it again? Well, here's what happens. Think about it and ask yourself this question, especially if you're insulin resistant and you know it. Did you feel it when you became insulin resistant? Were you aware when you became insulin resistant? If you have cardiovascular plaque because of your insulin resistance, were you aware when it happened? See, that's the point. We go along and our insulin receptors will take an incremental dip. Sometimes they'll get better, but sometimes they won't. So it's like we get worse and worse and worse. And that's why growing old is not for sissies. As we get older, the challenges increase. And so my question for you, Fort Worth, would be, as it often is for patients who ask that very same question. Okay, so the next time your insulin resistance increases, how are you going to know? So no, I don't recommend, you know, some people do it all day, every day, and just keep doing it. I don't recommend that. You know, they've actually done some studies looking at that. You don't get improved care when you do it all the time. However, I would strongly recommend doing this at least quarterly because you get an idea and you also get an idea of, okay, am I getting worse? Did I get worse over the past 3 months and not know it? A special warning in that space. I've wondered about COVID. Does COVID, you know, there's a significant inflammatory component to COVID. Has it been having an impact on insulin resistance? And the bottom line is yes. I had one patient that I remember specifically. She was doing okay. Her peak glucose values were getting up into the 160s, 180s, but she ended up having long COVID. And sure enough, about a few months later, we did a follow-up annual OGTT with insulin resistance. And all of a sudden, her blood sugars went up over 200 and her insulin levels went up over 200. Insulin levels had been less than 50 before. So that COVID infection, and in her case, it was a long COVID infection, evidently just really damaged her insulin receptors. So yes, there's a big deal associated with that, Fort Worth, and I would recommend it at least quarterly, at least every 6 months, even if you're stable. Bob Bell, I use my FitnessPal to determine those type foods that don't raise my blood glucose. But the database is not perfect, and I can be surprised with my glucose response. That's the point. We change, especially as we age, and we need to know because this is critical information. Don Berry, good morning from a low-carb senior in Michigan. Good morning to you, Don. Well, we just had one of those episodes where the questions flipped up because they're starting to pile up. Margaret D., good morning from Winnipeg. Thank you so much, Margaret. And again, after Margaret's good advice to us and reminder, almost 100 people, up to 100 people. Now we're at 73 people watching currently. We've gotten one thumbs up, one like. Think about it. Bobby Ocampo, Mabuhay to you too, Bobby. Thank you so much. Okay, Dave, the retired cop. Welcome from Minnesota. Thank you so much, Dave. Thank you. Good morning, Bambi. Joe Blow 2, or you can go carnivore and use MOTS C, 5 amino T, 1 MQ. I don't know these items that you're mentioning. I do have several patients that are carnivore, and you do bring up a good point. You're not going to get carbs on board when you're eating carnivore. Now, are you trading that off for other issues, other problems? You might be. And if you are, I think you need to adjust. I'm not afraid. I don't recommend against a carnivore diet, but there's just some adjustments you need to make if you're going to do that. And I'm a little bit skeptical about how long-term it is. Is this like diet needs to be a permanent lifestyle change, not a 6-month temporary thing. Terry Dixon, Indianapolis, Indiana. Thank you so much, Terry, for joining us. Fort Worth, are you familiar with the new GLP-1 receptor drug activator? Yes, tirzepatide. Tirzepatide is getting some great results. I saw that article about tirzepatide 2 or 3 days ago, and we're going to be covering that one specifically, a full content on it, Fort Worth, in not sure when, but in a few weeks. Really, really good information coming out about it. One of the we'll cover it. I'm not in a huge hurry to cover it because it's still early, and that's the problem. If you go immediately to a drug that's just coming out, even if it's got great reviews, that's what happened with. Gosh, I can't remember the name of the drug right now. The drug that caused phacomelia, the flipper babies. You need to be careful. You need to wait and get a lot of experience. And I don't think they've had enough experience yet to say that we know that tirzepatide is going to be safe. But huge, huge opportunity with that drug. Leo Acapulco, good to hear from you, Leo. Redevant in Mexico. Lily makes it pitavastatin calico. Leo, I read an interesting article. I think it was the Washington Post the other day about all of the American, it's Americans get so locally protective about, one of our previous presidents talking about bad hombres coming in from Mexico. This article was all about the bad hombres from the U.S. going to Mexico and trying to hide. Anyhow, I digress. E.T. himself, hormesis equals the Goldilocks zone. So great point, E.T. To get back to that comment, that discussion about hormesis, the reason they call it the Goldilocks zone is it's not too much, not too little, just right. For those of you who remember the story. Yep, so too much O2 in a hyperbaric chamber, you can get significant challenges and damage with O2 in hyperbaric chambers. Yes, thank you, E.T. That's what I was referring to earlier. Arthur Berry, Dr. David Sinclair pushes hormesis for longevity. What doesn't kill you makes you stronger. Now, that's not always the case, but it is very often with a lot of things. Otherwise, the body gets lax and thinks everything's okay. You're exactly right, guys. See, there's more guys out there that are familiar with hormesis than we saw or heard last week. Richard Carley, definitely worth watching David Sinclair's YouTube. I'm a big Sinclair fan. I've done, for a while, whenever he comes up and he gets acknowledged for something, my David Sinclair videos pop up to the popularity component, become much more watched. In other words, I'm a big David Sinclair fan. I've got a lot of David Sinclair videos out there. And one of my most favorite series, I did a series. It was about 10 videos on his book, Lifespan. And here's why. I got the book. I loved it. And I said, I started off while I was reading it saying, I need to do a series on it, maybe 3 or 4. But the more I did on it, the more I realized that David Sinclair's book, Lifespan, was all about the content that we already cover on this channel. So I did one on the chapters on metformin and glucose. I did one on the chapters on zombie cells. I did I did one on the chapter on the information theory of aging, which is a theory that's attributable to Sinclair himself, and a really, really good point. And again, we had covered that in terms of our own genetics section. So it turned into a series of 10 different videos. Very interesting, lots of fun, and I'm a big Sinclair fan. No trash in heaven. Love the teaching about the benefits of hormesis. If we're honest, we all need to get help getting out of our comfort zones. That is a very good point. It takes discipline to get out of your comfort zone, but it's required for good health. Sax Girl Hornboy, it's been a while since I've heard from you. Are there concerns about adding fenofibrate to Crestor? Yeah, you're talking about, a lot of people, a lot of docs are big fans of the fenofibrates for triglyceride problems, as well as other lipid problems, other cholesterol problems. It's a prescription drugs, and the more and more prescription drugs you add, the more and more opportunities you have for interactions. And, like some of the more popular drugs, there are interactions with the most common combinations, like with Crestor or the, I'm having a senior moment, or the statins. So yes, there are issues there. I won't go deeper into it other than to say I actually rarely use it. I have a lot more patients come to me that are using that. And when I say a lot, I would say it's actually a lot more coming to me than I use. And it's for that reason that I tend to not use it. I think there are safer, better, more effective ways of dealing with the most common reasons that docs tend to give fenofibrates. For example, making sure you just cut your carbs and do some more lifestyle related things. and go to lower doses on the statins. So good point, sack squirrel horn boy. How about adding an SGLT2 to a beta blocker and add an anticoagulant and the lipid drugs, Crestor and fenofibrate? The SGLT2s for sure. I don't use beta blockers very often. You have to use them for the major reason I don't tend to use those is they tend to be overused. They tend to be used for just blood pressure and decreased stress. But there are some times, especially with heart failure and post stents, post instrumentation, that you need to use beta blockers. I'm not familiar with any significant associated problems with SGLT2s with any of the things that you just brought up. Obviously, this is sack squirrel horn boy. This is starting to get into advice for you as an individual. And just a reminder, obviously, I cannot give individual advice to somebody unless they're a patient. And it sounds like, well, just some legal disclaimer. It's more than a legal disclaimer. The point is you got to know all the details about somebody before you can make a medical recommendation. But it's good questions. Thank you so much for bringing them up. Finally, any tips for getting Medicare to cover an SGLT2? That's a challenge. We actually, we had a patient recently, and I think one of the Farxiga brands had coverage, at least in this area, by Medicare. I'll go back and look. Both of these drug classes are very expensive, but unless I'm mistaken, Medicare does have at least one in each of the categories that they cover. Dave, the retired cop. In the past 3 months, my A1C went from 8.8. Ooh, that's a bad A1C. Down to 6.2. Congratulations. Big deal. You have made a very positive impact on your health. And how did you do it? Not through drugs, through lifestyle. And the most important lifestyle issue is dietary change. At what level A1C will I be considered out of the woods? Never. I'm sure that's a disappointment. A1C, if you've been up to 8.8, Dave, it's clear you've had, that's one of the criteria for diabetes. So it's clear you've had full-blown diabetes. Now, I have had a couple of full-blown diabetics actually not show significant plaque, but that's rare, very rare. And what happened was we obviously evidently caught it very, very soon before they were able to form plaque. But this stuff doesn't reverse. Now, you hear, I'm blanking on his name, the fasting doc. It's not Jason. The doc that talks about Fung. Yeah, Jason Fung. So you'll hear him talk a lot about curing diabetes. Well, yes and no. You take all the risks associated with diabetes off the table. And let me get back to answering more of your question. I feel a lot more comfortable with somebody once they get into the mid-5s and less in terms of causing cardiovascular inflammation. That's probably the answer that you were looking for. But when you say out of the woods, that automatically means to me that a cure. And cures don't happen. You take the risk off the table, but the minute you get back to the causative issue, once you gain that weight, for example, you're back in the same area. So the point behind all of this is, whatever change you made, diet and most often weight loss, body fat loss, you have to maintain those or you're going to be back in the same place. Now, to your point, at what A1C levels do I reach more safety? It's more like 5.5 or less. James Cantor, Dr. Brewer, you're still taking metformin for your diabetes? Short answer is yes. I have pulsed it forever, meaning I'll take it 4 or 5 days and then I won't take it for a couple of days. Now, I got you bring up a really good point, James. Folks talk about, especially with Rhonda Patrick, you've heard it with Peter Attia. I'm listening to a lot of Attia recently, and I'm not in the same place he is. He's much more into physical performance, athletics. I'm much more into health and lifestyle, life extension. And here's one of the things he talks about. I think this is a place where Attia and I would differentiate. He's all into showing his performance on a bicycle. And that's good. I actually was in that space for decades in my life. I'm less concerned about my performance on a bicycle now and more concerned about my safety and health. According to him, he did document some decrease in performance in his stage 2 areas, lower levels of performance with stage 2 on metformin. So that's what this big thing has always been about. And I get so many patients ask me, well, doc, I'm worried about metformin and my mitochondria. And my perspective has always been, well, it depends on your level of what your priorities are. If it's more important to you to be able to perform 10% better on a bicycle, in terms of stages of exercise, then, maybe metformin's not for you. But it's like, and Attia brought up the same point. He said, so now that I've documented it, I really got to ask the question, what's the most important? What's practical? So great question, James. You gave me an opportunity to go down that bunny hole. It's a real good bunny hole to think about too. James Cantor, I'm taking Ozempic. Thank you, James, for sharing. It has helped with blood sugar and weight loss. James has shared with us several times that he's diabetic, and he's followed us a lot. He's contributed a lot to the channel. James, I'd love to have you share your story on the channel someday. If you'd be interested and willing, let Michelle know and we'll get you set up. Bobby Ocampo, dapagliflozin, 10 milligrams, 44 pesos in the Philippines, approximately 80 cents US dollars. It makes me want to hold my head. All of this market approach to healthcare in the U.S., and I know I'm going to get haters for that comment, and total government delivery of healthcare is not right either. You see those problems in Canada and the UK. You see those problems in government delivered healthcare in the US as well. But look, this is one of the problems. These things cost, the dapagliflozins, the SGLT2s cost typically $800 a month in the US. And as Bobby's bringing up, they cost what? $25 a month in the Philippines. Sandra Dabrowski, there's a new weight loss treatment called Plenty. You need a script for it. No information how this affects insulin levels of taking it, as I've seen. Any thoughts about this? It sounds interesting. I've never heard of it. I'd be interested if, obviously I'm not going to take everybody's time to go look it up, but I'd love to send in the information on it, Sandra. Be very, very interested in hearing about it. And I'll say this, it looks like you're one of our few members joining us from Facebook. So thank you so much for doing that. Lourdes Colon, what are the counterindications for using Ozempic, non-diabetic patient looking to lose weight? Father had pancreatic cancer. I will tell you this. For the folks with a family history of pancreatic cancer, that is one of the red flags for the GLP-1s. If I had a family member with pancreatic cancer, I would strongly think about whether or not I wanted to risk using one of the GLP-1s. Great point, Lourdes. Thank you so much for bringing it up. Well, we got a lot of comments and the thing's flipping on me a little bit. Linda Buckner, at age 75, reactive hypoglycemia alerted me to a problem. My last A1C at Jubilee. Oh, well, thank you so much, Linda, for sharing. You know, I was out in the clinics yesterday and they were telling me they're getting more and more calls from people interested in seeing me through the Jubilee channel. We're working out ways to try, I mean, not through the Jubilee practice. We have docs. We have 12 docs and NPs that are seeing patients all day, every day at Jubilee. And if some of the negotiations that we've been having for the past 2 weeks complete successfully, we're likely to grow to 20. You know, we're currently at 6 clinics. We're likely to grow to 20 or 40. I mean, it's a big, big deal and growing quickly. Now, the question, you know, one of the questions that is coming up a lot is, can patients see me? That's going to take a little bit more time, but at some point we hope to be able to work that out as well. Gator Geek, he said, please don't use that middle word anymore. He's evidently not drinking beer. So Gator, CGM is good for more than just postprandial checks. Thank you so much. I didn't mean to imply that was it. I learned showers shot up my blood glucose. That is interesting. You know, and to your point, well, let me finish reading the rest of your question. I learned what exercises towards lowered versus raised blood glucose. Really, you're bringing up some really good points. I wish the sensors didn't inflame my skin so I could still use one. Well, that's hard. That's too bad. By the way, Gator, to that point, there are more and more sensors coming out. The amazing success that they're getting with the lower cost sensor with Libre. We used to have nothing but Dexcom, and it was like $1,000. It's much less than that now, but it's still very expensive. Then Libre came out, and all of a sudden you had affordable CGM. Now there's like half a dozen of them out there, and that's one of the topics we keep wanting to cover, but like there's only so much time in the week. I would suggest that you start looking around at other CGMs, Gator. You're getting a lot of good information, a lot of positive benefit from using it. Look at some of the others. I'm sure that, you know, the adhesive is not a goal critical part of that device. Try some others. You may get a better one. But just to go down some of the other bunny holes you just bring up. People talk about, well, eating to the glucometer. And that's the first thing that we push people to think about. Eating to the glucometer. Because eating is the most important driver of blood glucose. But it's also, once you start going there, it's sleep. And as Gator just brought up, even taking a shower, all these different things. And one of the bigger issues that you talked about is exercises. Some exercises increasing blood sugar and others decreasing it. You know, I began to experience it myself at about 2 years into getting fat adapted and 2 years into increasing my high intensity interval training and resistance training. As you start losing weight, losing body fat, increasing increasing fat adaptedness, and again, getting into these more intensive types of exercises, they can stimulate adrenaline, which in turn stimulates glucose. Now, is that dangerous? No, it's not dangerous. It's clearly good for you. But it's just another one of the balance items that you need to think about as you get into more of this healthy lifestyle. Linda Buckner, at age 75, reactive. I thought we covered that a minute ago. So, but again, thank you for sharing, Linda, and thank you for coming to Jubilee. Harvey Ops, 50 likes. Oh, really? You know, that's so interesting. I had that. That has happened before, Harvey. Thank you so much for pointing it out. I'm evidently only seeing a small portion. Right now, for example, I see 2 likes, and as Harvey's pointing out, there's actually 50 showing up on his side. Thank you again, Harvey. It's, you know, technology. Some people would say technology is like a spouse, a wife or a husband. A whole lot of benefit and a whole lot of trouble sometimes. Leo Acapulco, you have the thumbs up number wrong. Oh, thank you, Leo. Yeah, I only have 2. Harvey has 50. Maybe you have a number different from both of them. Fort Worth, I check my blood glucose 2 times a day, and it's a spot check because the test strips cost me $0. Just didn't think the $60+ a month was a good investment for CGM if I'm routinely checking my blood glucose with a meter. Yeah, that's a good point. Now, here's the place, though, Fort Worth. Remember this. When was the last time you were able to check your blood sugar at 2 or 3 in the morning, or 4 or 5? And when's the last time you saw that progression from midnight to 4 in the morning? You're not going to see it unless you're waking up and sticking yourself. And at that point, that might actually change the blood glucose values anyway. So the point being is there are times and specific things that you might want to know. For example, I do expect, and most of us, you're going to see that you would get what we call a nadir, a lower point in our blood glucose in those wee hours of the morning. And that makes sense. We get that with blood pressure, and that's been well documented. And it's also been well documented to the extent that we know that we want blood pressure to dip between midnight and 6 a.m. Well, I personally am seeing that with CGMs. We tend to see blood glucose dip at that point in time. Many of us getting into the 60s and even 50s. And I've had 2 patients just over the past week say, oh, you know what? I stopped my glucose. I stopped my metformin because my blood sugars were getting that low at 2 in the morning. In fact, 2 weeks ago, I had a patient call Michelle and get set up with us. She said, my alarm is going off at 2 and 3 in the morning on my Libre. And it's because it was getting into the 60s. And she said, the alarm was going off, so I was getting up and going down to the kitchen to get something to eat. And it was like, oh, gosh, I'm sorry you did that. You shouldn't do that. It's a sign of getting fat adapted and healthier if you're getting those lower blood sugars between midnight and 5 in the morning. There's a thing called a Somogy effect, which is your blood sugar getting way too low and an alarm going off. You wake up, you test it, and it's actually gone high. That's really for patients on insulin, and unless you're on insulin, I don't see a reason to go down that bunny hole. For the most part, this is a healthy reaction to getting fat adapted. So, as you might imagine, it's like every solution creates a whole new set of problems. These CGMs are a major, major solution, and yes, they do create a whole new set of problems. We have, Michelle is now providing some written instruction as well to make sure that if we wrote you a script for a CGM, we also made it clear to you that you want to see these lower levels. And by the way, this Libre, Libre, I think has an automatic set point on the alarm of like 70. And it's like, oh, that's too low. That's too high. That's for somebody that's on insulin. We don't want that for folks that are at a lower level of insulin resistance. And clearly for folks that are not on insulin. Anyhow, I think I'm getting repetitive. I'm going to move on. Fort Worth West Side, thalidomide. Yes, you're right. She was talking about I think it might have been Fort Worth that brought up the tirzepatide or whatever. And I was giving the warning about going too quickly to jump on a new promising drug. That's exactly what thalidomide was. It was a new promising drug. A lot of people, obstetricians, gave that to women for getting nauseated during pregnancy, and we had some horrendous birth defects as associated with it. Children actually lost their arms and legs and had just, they only had hands sticking out of their trunk. It was terrible. And again, that's what can happen when you jump too quickly to a new promising drug. Bobby Ocampa, dapagliflozin, requires no prescription in the, wow, no prescription in the Philippines. Well, you know what? I don't know how I feel about that. I do wonder if that's, that might actually be a better scenario than a prescription level. I certainly don't think metformin should be a prescription drug. But I might get filtered for saying some of that. Anyhow, Drax of the North currently taking 40 milligrams of Crestor. That's a very high dose, by the way. Lead a very active, strict, low-carb diet, intermittent fasting lifestyle for 2 years. Yet A1C has gradually increased from 4.9 to 5.6. Anything I can do? Crestor at 40 milligram levels tends to have a very significant increase in insulin resistance. And as I mentioned before, and I've mentioned multiple times on these videos, I get very concerned about people on higher doses, especially this higher dose. I tend to use 5 per day or less, and often less. And those levels tend to not cause insulin resistance. Clearly, 40 of Crestor will cause insulin resistance. Residency, yep. So, like I said, I'm not going to, again, go into, I don't know you. I don't know the pros and cons. I don't know what's going on with you, but I can tell you, I cannot remember ever using 40 milligrams of rosuvastatin. Bart Robinson, hello everyone. Just checking in a little late. I'm on the beach in Ocean City. Oh, you had to rub it in. So Bart lives in New Jersey, and now he's on the beach in Ocean City. Thank you for joining us, and thank you for letting us know. And just like Fort Worth, I am jealous too. Brendan Lenane, I often have intense, even brutal Chinese Thai massage therapy. I'm not sure why I'm coughing so much. Sorry about that. As I had major thoracic spine surgery as a child long ago, does this guided therapeutic inflammation negatively affect cardiac health? No. There's different types of deep muscle massage, and I'm blanking. There's some specific names for it, and it gets to where it's pushing hard to lengthen the muscle fibers deep, which is one of the benefits. That tends not cause the type of inflammation that we're talking about. I will say this: we've got some inflammation. We've got a lot of content on cardiovascular inflammation. We look at different tests for it. There is one test that it might impact, and that would be high sensitivity C-reactive protein. But that one is the most common biological false positives out of the cardiovascular inflammation testing panel. It shouldn't impact myeloperoxidase. It shouldn't impact Lp(a), and it shouldn't impact microalbumin and creatinine ratio. The other thing would be that, if we give 100 people today a flu shot, in 48 hours, 2/3 of them will have elevated C-reactive protein. Bruises and abrasions can cause elevated C-reactive protein, but again, not the others. So I hope that was helpful, and thank you so much for asking. Our question list just flipped again, indicating that we have a whole lot, as often happens. It looks like we're not going to get to to all of our questions today. We're going to cover, I think it's getting to where if you want to get your question answered, you have to get it in there early, folks, because we're getting to where there are just too many being covered. It does bring up a point. And Gilbert, if you want to show that overlay, we are developing more of a community type of access with a platform called Locals. And we're starting to get a lot more content out there. We're going to be developing it to where we have more protracted discussions, and I'd love to see you there. Anyhow, let me see if I can cover a couple more before I have to go. Gator's describing more and more problems associated with skin irritation on the CGM. Jimmy, for a drug like Farxiga, do you need to use it every day, or could it be something that can be done a few days a week? With most drugs, you can use them a few days a week, and I tend to do that a lot. You have to ask the question, though, given what Farxiga does. Farxiga is a SGLT2, by the way. Does that help? One of the things that it does, I will tell you this, that I'm not aware of any, and I don't think there is any significant evidence out there about actually using it, pulse therapy, a few days a week and then not using it. And you just don't see that a whole lot because you rarely see true official indications for it. So you're in a position of having to say, okay, does it make sense? And B, talking to a physician that may have a lot of patients that do that. I have not had enough patients agree to start taking the SGLT2s, let alone to be able to say, okay, yeah, I know from my patient practice that you get a lot of that and that it works. Do I recommend an extended release of metformin? Not usually. Usually when I start people on it, I'll always start them out on the regular metformin. Now, here's what I will say. I do get a few people that have problems with, especially dawn effect. And a lot of our dawn effect folks end up getting a better response from extended release metformin. And Fort Worth mentioned she does have dawn effect. About 20% of folks can have it. And again, as you get more fat adapted, more people tend to get dawn effect because it's, dawn effect happens because of cortisol. And as you get more and more used to burning, more fat adapted, there's a little bit more of a cortisol role there. Not on a lot of people think it's unhealthy. I'm not going to go down that bunny trail because we can't today. But another question: Does metformin, interesting spelling on metformin, does it tend to prevent the dawn phenomenon? Also, extended, as we were talking, DJ. Quite often, extended release metformin will help. Is there a continuous ketone meter now? No. Well, I don't think so. Here's the other thing. You bring up a great point, Bobby. What we really want is something that will do continuous monitoring for ketose, glucose, and insulin. We don't have that yet. That's for the future. Keto Man, happy with Jardiance. Can I have an opinion, please? Yeah, it's one of the things that I've been able to get a lot of, of that drug class, I've been able to get a significant number of people on Jardiance. I'm a big fan. Gator Geek, Rick Farnbach, that was not the problem with the shower. Same readings, verified a glucometer, still happens. Okay, Gator. It was also not compression lows with the Libre. Happened even when awake. It just flat out didn't work for me. Again, I would try some other CGM. And again, folks, had a lot of interest, a lot of fun on this topic today. If we were unable to get your question answered, come back another week, get it in there earlier, try us on locals. Thank you again so much for your interest.